Welcome to this episode of CRST, the podcast. In today's program, Professor Stefano Barabino, Professor of Ophthalmology and Head of the Ocular Surface Center at the Sacco Hospital in Milan, Italy, will lead the second of three discussions focusing on dry eye disease, or DED. In this episode, we'll discuss the diagnosis of DED in everyday practice, including the standard diagnostic techniques as well as more innovative technologies. We will also discuss the measurement of inflammation and the role of blepharitis.
So dear colleagues, thank you very much for joining us for this second podcast. In the first one, we talk about dry eye, and in particular, we try to define dry eye and to explain what is dry eye. Today, we are talking about the diagnosis and management of patients with dry eye disease. I would like to thank Professor Margarita Calonge, who is with us today. Marga, if you wanted to introduce yourself.
Hi, thank you, Stefano, for inviting me. So I am currently full professor of ophthalmology in the University of Valladolid. Valladolid is in the northwest part of Spain. And there we have an institute in which we have clinical research and teaching. So my role there is in the clinical arena. I am the director of the ocular immunology unit. We have just created a oculofacial pain unit. And I'm also in charge of the cell therapy unit. And in research-wise, I coordinate a group of about 25 people, and our main focus is ocular surface and mainly dry eye, in fact. I think that sums it up.
Thank you very much, Marga. And it's also my pleasure to introduce James Wolffsohn. James, you want to introduce yourself?
Sure, Stefano. So my name is Professor James Wolffsohn. I'm an optometrist at the University of Aston in Birmingham in the centre of the UK. I do a lot of research in dry eye contact lenses, intraocular lenses and instrumentation. And we have our own dry eye clinic there. And I'm also the Associate Pro Vice Chancellor for Research Integrity.
Thank you very much, James. One of the aim of this podcast is actually try to give messages and combine the basic science with the clinical practice and the everyday practice and see to really how to manage our patients. James, who are the patients with dry eye and why they are complaining about the symptoms? What are these symptoms in particular?
Okay, so from the TFOS used to definition of dry eye, all dry eye patients have both symptoms and signs. So dry eye is a subset of ocular surface disease, and they are the people who that ocular surface disease is causing symptoms. And of course, then there's the differential diagnosis to make sure this isn't another disease such as allergy or infection. So symptoms is a really important part of dry eye disease. And in terms of diagnosis, of course, we have to do that in a standardized way because we want to make sure that there's consistency between us as practitioners when we make that diagnosis. So the committee, TFOS, decided on two questionnaires, the Ocular Surface Disease Index, which has 12 questions, or the dry eye questionnaire with its 5 questions as the core diagnosis of dry eye. In terms of those symptoms, of course, we want to understand both the severity of them, but also the frequency of them. Both of those play a part. And of course, they're quite complex. This is a multifactorial disease, so those symptoms differ in our patients in terms of when they're worst and the sorts of things that provoke those symptoms.
And what about your everyday practice? I mean, do you see many patients with a dry eye? And also, is there any relationship between a dry eye and contact lenses? I know that you are an expert in this field.
Yeah, there certainly is. And if you look at the causes of dry eye, both on the evaporative form and on the aqueous deficiency form, contact lenses can play a role. It's quite interesting with contact lenses because actually we use them as a treatment as well. So we use bandage contact lenses as a treatment for severe ocular surface disease. So they can be part of the solution as well as part of the cause. So it is about practitioners optimizing the lenses. And there's obviously some really good lenses now on the market, particularly those with a really slippery, lubricious, as they call it, surface. They seem to be much more comfortable for patients because you don't get the friction between the lens and particularly the eyelid motion. So it's certainly something to pick up in your history and symptoms if they're a contact lens wearer, and if they are, to deal with the issues to do with the contact lenses first, and also to differentiate between those people who had dry eye before and the contact lenses perhaps contribute to that a little bit, and those people who never had dry eye but the contact lenses push them over the edge, because obviously it's different in terms of our management then. One becomes purely a contact lens option issue, the other one you have to do a combination of both.
Thank you, James. So let's talk about the diagnosis. Marga, is it difficult to diagnose dry eye? I mean, some colleagues of mine say, oh, you have a lot of time to diagnose dry eye, and then you can do a lot of tests. That's why you don't miss the diagnosis. But probably this is not the reality. I mean, how do you diagnose patients in your everyday practice? And what are the suggestions that we can give to our colleagues?
Well, I think it's very easy to misdiagnose dry eye, in fact. To me, the diagnosis is very difficult because it implies that you have to do a very good clinical history. And this is something that, unfortunately, we are doing less and less, worse and worse. And by doing a clinical history, you realize that several of the dry eye people that have been referred to you as dry eye, they don't really have dry eye, but other diseases. So it is often misdiagnosed. So clinical history is important. And the main thing that it is misdiagnosed to me is atopy. Many of these patients have AKC, atopic keratoconjunctivitis, and nobody has asked them about the atopic dermatitis that they have or they had in the past. And the symptoms are very confusing because they are mainly the same. And one thing that I find useful is the OSDI. If you see a OSDI with all the answers are about 1, 2, and not really in the, in the more 3, 4 score, you know that this is not really dry, but it's something else. And these people have one of the symptoms is dryness, and they can have dryness. So to me, first, what we have to do is to make a good clinical history and really realize that whether or not we are in the field of dry eye or something else that is very easily confused.
Yeah, I totally agree with, sorry, correct.
Go ahead, please.
I was going to say, I totally agree with you there. I think the history is so important to get right in terms of the diagnosis of dry eye. And likewise, symptoms, as you say, can come with a variety of different conditions, not just dry eye. The OSDI really records the frequency of symptoms, not the severity. And dry eye tends to be something that is there the most of the time. So it does tend to be the people with the higher scores.
I remember a very famous person in the field of ophthalmology said that any chronic ocular surface disease will end up developing dry eye. So the patient might have dry eye, but you really need to go back in history and see what caused that dry eye. Otherwise, you don't really never get them free of symptoms and free of signs. So that's what I was trying to say. And then in terms of symptoms, I don't know, James, what kind of questionnaires you do? We do routinely for any patient coming with dry eye symptoms, whatever he or she might end up having. We do an OSDI, the visual analog scale, for the worst symptom and also for pain, because we are very much interested in pain and we are trying to see we are catching pain also. And the CDEC. And then a very simple questionnaire that we have just published, which is the dry eye severity questionnaire. And this is not for the first visit, but for the second one, just to say whether the patient has improved impaired or is the same, and if you improved or are worse, how much. And so that's the symptoms we are doing right now.
Yeah, we would always do the OSDI because that's one of the diagnostic criteria. But also I like the visual analog scales and particularly the SANDI questionnaire. So that has essentially 2 visual analog scales, one for the severity and one for the frequency. So that sort of gets in that severity element as well, which I think is really important, and particularly then when you're talking to patients about appropriate management.
Marga, in terms of test that you perform, and once that you listen to the history to your patients, then you know that it could be dry eye or anyways, it's an ocular surface disease. Last time with Maurizio, we talked about a lot that dry eye is a disease of the ocular surface systems. But in terms of diagnosis, what are the tests that you use in your practice?
Well, I think we all agree and we all do the same ones, the basic ones, which are, of course, you have to examine all the ocular surface first, the conjunctiva, flip the upper eyelid, see if there are macro papillae there that would suggest atopy. Then, of course, the lid margins are essential because meibomian gland disease is extremely frequent. But again, some people may have a lot of signs of meibomian gland disease, and that is not responsible of the problem. And then once all this has been examined, I usually put fluorescein. I use the strips, and with that I do the BUT and fluorescein staining, and also lissamine green staining. Although lately the lissamine green staining that I have is not giving me any staining, and I'm relying more and more in fluorescein staining in the conjunctiva too. This might be wrong, but I'm having a lot of problems with lissamine green, and we don't have rose bengale available anymore. Then after that, I do. Usually the technician or the nurse do a Schirmer test. We always do it with anesthesia. And it's something, usually in the normal regular clinic, I don't do any other tests because all the others like mammography and the most sophisticated tests, we do it in the context of clinical trials and not regularly in the clinical, in a regular clinical session.
But I think that you and James agree with me that if you use a fluorescein and a lissamine green, we have almost all of the information that we need to diagnose the dry eye. And I agree with you about the lissamine green. The lissamine green in strips doesn't work very well to stain the surface of the eye. I have to say that in Italy, we are lucky enough to have a new liquid formulation of lissamine green that comes with a dispenser that makes a drop of 10 microliters. So we can stain and get a lot of information because we can stain the conjunctival cells, we can stain the lid margin. We can see, for example, if there is a superior limbal keratoconjunctivitis. I mean, we can get a lot of information because this stain is tremendously important. James, is there anything else that you do in your everyday practice? And or this another question, what about these new technologies? If you can explain to us what are these new technologies, what are you using, and what do you think are useful? And of course, Marga, if you can give also us your comments about these new technologies. Please, James.
Sure. So obviously I need to declare that I was the chair of the diagnostic committee of TFOS Use 2. So we did a lot of work around appropriate diagnoses because as we've all acknowledged, there are lots of different tests out there and you've got to select between them. You haven't got infinite time with your patients. But as well as symptomology, which of course is critical for your diagnosis of dry eye, we're looking for those markers that show the homeostasis of the tear film has been disrupted. So we're looking for less invasive tests if at all possible. So we would always do a non-invasive breakup time. I'll talk a little bit about the technology to do that afterwards, but I think that's becoming more standardized. And the advantage there also is a lot of the new instrumentation will do that more objectively. So the computer will detect it rather than you having to look for it, which obviously makes things easier. Also, you can pull back on that instrument and have a look then at the interferometry from the lipid layer. So again, that gives us a bit more information when it comes to subclassification. Osmolarity, we do have in the clinic. We tend to use it more in research studies, but it is part of the possible ways of seeing that disruption of the homeostasis of the tear film to look for a diagnosis. And we do always use both fluorescein and lissamine green. Very interesting to hear you talk about lissamine green. There was a paper last year looking at the different strips and showing that they're not all equal. So they do stain very differently, and there are stains on the market that really don't stain at all. So TFOS Use 2 recommended that you left the drop on the strip for at least 5 seconds to increase the concentration. And we've demonstrated that in the lab, that actually that makes a big difference. And you pour the whole drop into the eye rather than just a minimal amount like you would do fluorescein to get that staining. But we are working with some of the manufacturers to make sure that we can get a more consistent lissamine green. But it's great to hear from Stefano that there may be a liquid form available as well, because I think that would benefit us very much. Although we've got to acknowledge that worldwide there are some countries that are not allowed to use it, unfortunately. So while I think it's a really useful dye and critical to the diagnosis of dry eye, unfortunately not everybody has access to it. And then moving on from the diagnosis, we would then do things like tear meniscus height to look for more aqueous deficient dry eye, again trying to get away from the more invasive tests like Schirmer and phenol red. And we would always do meibography to have a look at the structure of the gland, expression with a Korb expressor to have a look at the functionality of the glands, as well as the interferometry, as I said, to have a look at the oils on the surface. In terms of new instrumentation, there seems to be a new instrument every month. We've just evaluated 7 different instruments. What's really nice is some of the multifunctionality that they have now. So not just non-invasive breakup time, but they do the infrared light to allow you to do the meibography, the interferometry as well. Some of them are doing automatic grading of redness. So they are quite powerful in the clinic in terms of understanding and also presenting that information to the patient. So again, really great reports for patients to really understand where their disease is at now, and also therefore where you manage to get them to with treatment. Expense-wise, some of them are pretty expensive, but some of them are relatively inexpensive. So they sort of vary from about 1,500 euros up to the 20,000, 30,000. So we have a variety of this technology, and we're currently trying to understand what makes better technology in terms of the light sources they use, for example, and the imaging systems. But there are some really impressive systems out there now. But it sort of puts dry eye as something that it can't really necessarily then be done in normal clinical practice. I'm not sure they have the time anyway. It is quite a speciality.
Marga, what is your experience with these new techniques?
Well, again, what I can do in the regular clinical practice, where we have 20 minutes max for each patient or half hour, is all that I said before. Maybe I didn't comment on the fact that I do expression of the eyelids and see whether I think this is very important to determine the quality of the meibum, actually.
Yeah, absolutely.
Meibography, I don't do it regularly because just by examining the eyelids in the slit lamp and flipping the eyelids, I can get a pretty nice idea. If I have the time, I do it, but many times I just can't, and it's quite easy to imply where you are going to see in a meibography. And all these techniques that you have mentioned, James, study of the lipid layer, for instance, impression cytology, we used to do it, we don't do it anymore. Meniscus, all that, we'll relegate that for clinical trials when you need like much more time for each patient.
Sure, it does take a long time to do. The meibography is nice because it's really powerful with the patients. They really get it that these glands have been damaged, and obviously therefore a bit more motivated for the treatment. but yeah, it does take time, and I'm quite an advocate for not trying to sort of squeeze this into sort of a standard eye test, that this is a specialist service that you're offering patients, but obviously that then has time and cost implications for the patient and the clinic.
We didn't talk about inflammation. We know that inflammation is so much important for dry eye in terms of diagnosis and in terms of treatment. Marga, what is the role of inflammation in a dry eye, and how can we diagnose it? I know that you have a lot of experience, you have a very nice lab. So can you please help us to better understand how to diagnose inflammation?
Well, we have, I think it has been established already, Stefano, that inflammation is takes always part, is the pathogenic mechanism to causing dry eye eventually. It is the pathway. It's not that it is, we don't know the initiated agents in many types of dry eye. We know, of course, in other types. But inflammation is the way that you know, that nature takes to produce all the damage that we see in the ocular surface. And inflammation has been demonstrated there anytime it has been looked for. It might be much more relevant and knowledgeable in dry eyes like Sjogren's dry eye patients, but it has been demonstrated also in meibomian gland disease and in any disease. So that's why, and actually, as you mentioned, our contribution to the world of inflammation in dry eye has been through cytokines, inflammatory molecules in tears. We have a lot of experience in that. We have looked for all kind of molecules in tears, in contact lens wearers, differentiating symptomatic from non-symptomatic lens wearers in any kind of dry eye, and we have always demonstrated elevated cytokines. We have a little bit of different profiles, but you know, the typical cytokines, interleukin-6, MMP9s, interleukin-1 receptor antagonist, interleukin-8, IP10, more or less always the same kind of molecules are elevated. And of course, a decrease, which is about the only one that decreases epithelial growth factor. And it has been proved that the lower the levels of epithelial growth factor, the more severe the dry eye is. And when you treat these patients and you improve them, these inflammatory molecules decrease and EGF increase. And this happens in meibomian gland disease, in Sjogren's, in grass-versus-host disease, in any kind of dry eye. And that's why I'm a big believer of treating these patients with anti-inflammatory therapies. I mean, everything is very important, lead hygiene, all the in-office lead hygiene treatments that we might talk about later. Of course, artificial tears, anything but anti-inflammatories are, to me, essential if we want to have a long-term management for these patients.
And in terms of diagnosis, Marga, in the everyday practice, I mean, you look at the conjunctival hyperemia, you do any tests, you do impression cytology in all of your patients, or just in clinical trials?
I used to do impression cytology in any patient. I don't do it anymore because I always find the same, more or less amount of goblet cells and some kind of metaplasia in epithelial cells. So I stopped doing it because it doesn't really help me much, unless you want to do investigations with that, special stainings and all that. And it's very difficult to demonstrate inflammation because the inflammation related, associated with dry eye is not that kind of inflammation that causes usually a red dry eye, with the exception of meibomitis, usually in the context of rosacea, that will get you a red eye. But usually the inflammation in the dry eye is in the conjunctiva, the stroma full of lymphocytes, and that doesn't cause a red eye. The vessels are not dilated and you don't see a dry eye. I mean, these people are very symptomatic, very dry, and they might have a little bit of red eye, but not the type of red eye that you will see in a bacterial conjunctivitis, for instance. So that's very well known. So inflammation is not always a red eye, and dry eye is the example of that. So you just have to believe that it has been demonstrated that there, when you are examining this patient, the conjunctiva is inflamed, it's full of inflammatory cells, and the tear film is full of inflammatory molecules. And because it has been published and demonstrated, you have to believe it. I don't think it really makes a lot of sense to try to do for diagnosis MMP9 or this kind of molecules, because first, because it's been very difficult to find a really reliable test that it works in 100% of people. And we just have to assume that inflammation is there.
Yes, I agree with you. I mean, it's a problem that we have in our practice. We know that inflammation is there.
It is a problem.
But we cannot demonstrate it unless we use specific techniques. But
exactly, because we don't see a right eye in many cases. So
exactly.
have to change that to, our colleagues that are not in the dry eye will think, well, your patients seem not to have anything because, they look at their eyes and the other side are white. But this is the eternal problem with dry eye people. Exactly. They suffer a lot and they can't show it.
Exactly. James, one last question regarding blepharitis or meibomian gland disease. We know that it's a very common problem. Again, how do you manage your patients from a diagnosis to treatment? We are not talking about the treatment today, but just to have an idea. I mean, what we should explain to our patients.
So yes, you're right. It's very common in our patients and seemingly more so. And we've started to see meibomian gland dysfunction even in very young children related to how much screen time that they use now. So I think it's going to be a growing problem for us all. So we do try and explain to patients what's happening and show them things like meibography. That's, as I said before, a really powerful tool to explain to them the importance of hygiene of your eyes. We explain about the meibum and the need for those lipids to flow on the surface. And again, that leads naturally to some of the eyelid warming treatments, which can be very effective. The ones either that they use themselves, such as a warm mask, or ones that we can do in office, such as IPL and LipiView and many new office treatments that are coming into that space. So that idea that in some ways it's more like dentistry than traditional eye care, that you have to do something daily to look after yourselves. That might be drops to reduce your symptoms, but also a warm compress to keep those oils flowing. And then the idea that at the regular checks, we can clean them up and do a more a stronger treatment, like an in-office treatment, but also things like debridement if necessary, if there's keratinization along the lids.
Blepharitis is a chronic disease. So
absolutely.
They can be better, but they have to keep using this kind of treatment, right?
Yeah, no, absolutely. And some of the newer treatments with lid wipes, etc., can make that a lot simpler for them to do than, when I trained, it was all about baby shampoo. But again, that's been shown that can inflame the ocular surface. So we do want some things that really help in terms of the management and don't hinder, and also easy to comply with.
So in conclusion, we can say that dry is a very complex disease. We have some instruments that we can use in the everyday practice, like fluorescein staining and lissamine green staining. And in most of the cases, we can make a diagnosis. What is very much important is what we said at the beginning. So we have to listen to our patients. Maybe we have to spend some minutes, but if you listen carefully to our patients, then probably we will not miss the diagnosis. And also it's important to talk to our patients, explaining what a dry eye is. In most of the cases is a chronic disease, as well as blepharitis is a chronic disease. So we cannot give a solution that lasts forever, but we can definitely prescribe treatments for a prolonged period of time. So I'd like to thank Professor Margarita Calonge and Professor James Wolffsohn for being with me today and to talk about dry eye. We all do research in this field, and we are working very hard trying to find some solution to open questions such as how to diagnose inflammation in the everyday practice.